On behalf of Karyopharm Therapeutics, I want to welcome you to our program today. My name is Tracy Bonds, and I'm a Karyopharm nurse liaison for the Southeast region. We have an exciting program planned today. In honor of Oncology Nurses Month, we're celebrating the many faces of oncology nursing. Whether it be at the bedside, supporting patients through clinical trials, or one of the various disciplines within the field of oncology, today we'll be hosting a panel discussion between established oncology nurses from various subspecialties in oncology, as well as graduating nursing students seeking to carve out their path in nursing. We have joining us today an oncology nurse practitioner, Daniel Verena. Daniel joins us today from Mount Sinai Hospital in New York City. Next, we have Kathleen Mcdermott. Kathleen is a nurse navigator at Dana-Farber Cancer Institute in Boston, Massachusetts. We also have joining the panel today, Doyle Bosk. He's an associate director of nursing with a focus on clinical research at MD Anderson Cancer Center in Houston. Last, however, not least, is Elizabeth Maheron. Elizabeth is a bone marrow transplant nurse at Rush University Medical Center in Chicago. We also have moderating our panel today two nursing students from the University of Massachusetts, Boston. First is Hundell Eulis, a rising senior in the nursing program, and Faith Karoma Coker, who graduated earlier this month from UMass Boston School of Nursing and Health Sciences. Thank you all for joining us today. We're truly looking forward to an engaging conversation around the diverse roles in oncology nursing. As a facilitator for this webinar, I'd like to turn it over to our student moderators. Faith, would you like to begin with the first question?
Yep, of course. Hi, everyone, and thank you for joining us today. I'm super excited to hear what all of our amazing panelists have to say. So first off, this is a question for everybody, but I'd like to start with Elizabeth. How did you choose your career path?
So nursing is actually my second choice career. I started out pre-med when I first went to school and decided pretty quickly that wasn't going to work for me. Turned myself into a psych major, worked in HR for a while, and then realized I missed the boat on nursing. So I found myself enrolling in some extra classes to update prereqs, and then ended up as a second bachelor's in nursing. And that's how I ended up here 13 years ago.
Nice, thank you. Definitely have some similarities there. Daniel, I have the same question to you.
Wow, I think we're all like twins. So I definitely am a second nurse. My first degree actually was pre-med. Got into some research and then got into health fitness for a period of time, but then was not satisfied. So just like Elizabeth, I went into kind of an accelerated 15-month program to get my bachelor's, and then quickly progressed through nursing to get my nurse practitioner degree. I think it's the best fit.
Great, thank you, Daniel. Kathleen, how did you get your role and what do you do from day to day?
Well, so my role is as a nurse navigator at this point. I started back many years ago and kind of worked through the system. I've been a medical nurse forever. Started out on a medical floor, went outpatient and outpatient chemotherapy. Always pretty much once I met my first leukemia patient up on the floor, the nights and dealing with them, heme has been my love. Then I went to outpatient infusion and then to bone marrow transplant and now into the CAR-T nurse navigation. So basically right now what I do is I navigate patients through the system, through their journey through CAR-T. And I bring them and get them to where the experts of taking care of them on the floors or in the clinic or in the apheresis unit. So that's kind of what I do. I kind of help them and their families regarding education and getting through the process.
Wow, that sounds super exciting. And last but not least, we'd love to hear about your journey, Doyle.
So many years ago, I was going to be a doctor, or wanted to be. And then I talked to a physician and he said, no, you do not want to be a physician, you want to be a nurse. Because in the future, nursing will set the tone for patient care. And I was so glad I took his advice. And then I was in the OR for several years, and what I missed was the continuing care of the patient. When in the OR, you see them, they do procedure, and then they're gone and you never see them again. So I was fortunate to get into research at MD Anderson, and this allowed me to be a part of the patient and the patient's family along their continuing care during their journey through cancer care.
Thank you for sharing. And now I'd just like to ask to you all again, how do patients impact you as an oncology nurse?
I think that being an inpatient nurse, I spend, especially in oncology, and I specifically work with the hematology and stem cell transplant patients. So they tend to have very long admissions, very frequent admissions. And so you really get to know them. So I definitely think there's I try to impart something great to them, but they also certainly impact me. I mean, you really get to know these people and their families. I learn things from them every day, both related to their disease process and related to the external world. I just got some advice on plumbing the other day. I think you really, you take away a lot from these patients because you spend so much time with them. You really get to form relationships with them, and it's really can be a two-way street, which is really what I love about the oncology world.
I agree. I'll jump in. I agree with Elizabeth. No, I think they do. I think in both two-way streets, there's always a pearls of wisdom or pearls of fun or knowledge from both ends. What I take from them is either saying, living through their happiness, because I'm a multiple myeloma specialist. So really seeing them grow, and then if they get to a special event, really how much they enjoyed getting them to that event, whether it's a birth or a wedding or graduation, whatever it is. And just like Elizabeth said, and I agree, it's really learning from them, learning about different movies or art or fashion or whatever it really is. They bring to us, I think, a lot of knowledge and experience, and then we can share ours with them.
Yeah, I agree with everyone. It's a two-way street. They with the bond that we connect with them and their families is so special, especially during a vulnerable time in their life. And I'll give you a story how it works both ways. This is the one that stands out to me. I was having a bad year. A lot of my patients' outcomes did not go well. But I had a patient, and he was a big guy, elderly patient, big guy, used to play football. And we had developed a bond. And one day I was in the clinic, another patient didn't have a good outcome. And I was really questioning myself as if I was doing anything good as a nurse in this field. And I was rounding the corner, and unbeknownst to me, he was rounding the other corner. He was having a bad day. We saw each other. We gave each other a huge hug and stood there and spent about 30 minutes together. And that told me everything I needed to know that, yes, I was making a difference in oncology. So that's always been a very special relationship with me. And I always remember that.
And for me, I learn so much from my patients. And whatever pearls of wisdom they give me, I can share with other people going through it, because I've never been in the bed. I've been blessed with good health. I've never been in that bed. So I can tell people what it's like to be on this side of the chair or whatever. I can't tell them what it's like to be in the bed. So the issue of gathering these pearls of wisdom regarding what strategies have worked for patients and their families who have been through it, I can tell them stories. And I think that is really critical with regard to having credibility and developing trust with patients and their families, and be able to say, listen, I don't know what it's like to be in that bed, because, but this is what someone told me would work for you or your family members. So again, so that's what patients really, really are a huge part of this collaborative of us taking care of them.
I second that, Kathleen, and thank you all for sharing such touching stories. And now I'm going to hand the mic over to the other panelist, Handel.
Hi, everyone. It's great to be a part of this session, so thank you for having me. For my first question, I'd love to hear what type of challenges you encounter in your roles as oncology nurses. Kathleen, let's start with you.
Well, challenges. I think part of the challenge is not everybody is the perfect patient. They don't have the perfect family situation. They don't have the perfect finances. They don't have the perfect medical insurance. They don't have the perfect travel or transportation, et cetera. And one of the challenges is trying to how to tailor the care they need to where they're coming from with regard to whether or not they have children, whether or not they have a dog they need to worry about, and they're the only one to take care of the dog. I mean, I really think that is one of the huge challenges, especially in this day and age with regard to where we are. And COVID has made a huge impact on how do we develop care and manage people, not only how we're going to get them in and how they don't have a caregiver and they can't have a caregiver in the building with you, as simple as that. But I think that is one of the huge challenges, is trying to figure out and assess where the patient is and how are you going to maximize, because you're not going to fix their social situation or whatever, but how can you make it to make sure they get the care that they need?
Definitely. Thank you for sharing. Doyle, what type of challenges do you encounter in your role?
I agree with Kathleen. I think knowing your patient's status and the family support that's surrounding them, and finding the resources that they need to help them through their journey in oncology. That's usually the biggest challenge, is gathering all the resources together, connecting the family and connecting the patient with those resources so they don't feel alone, because they are stressed enough. They don't need to have the additional stress of trying to find the resources that they need. That's part of being a nurse and caring for them.
Phenomenal points from the both of you. Elizabeth, let's switch gears. What enticed you to become an oncology nurse?
I was attracted to oncology specifically for a couple of reasons. Number one, I had personal family experiences with cancer. A very close aunt and my grandmother. And for both of those people, we utilized hospice services. And specifically with my grandmother was in this hospice facility that was, I mean, it was like the Ritz-Carlton of facilities that just, and I don't mean that just from a structural, but like the staff was amazing. The people were amazing. Like it just, and it really opened my eyes to, oh, like these people are really doing something amazing, and made me really step back. And that was at a time where I hadn't quite made my career jump into nursing yet, but it very much opened my eyes to, oh yeah, this is exactly what I want to do. And I think I still tried to go into nursing school with an open mind of, well, let me not just forge down one road exactly. But I think the more I studied and the more I saw, it confirmed that I liked the oncology world for the patient impact, and also just it's a ever changing and ever evolving. There's a lot of science going on there, and there's advances and things all the time that just make it interesting and exciting, challenging too, but a very fast-paced kind of fly by the seat of your pants world sometimes, and I liked that. Not enough to go into the ER. But I like the constant, the evolution of things and the constant trying to make something better. So
Wonderful. And you, Daniel, what pushed you to become an oncology nurse?
So in reality, I always never wanted to be a nurse, and I'll just be very honest with that. I really just wanted to be a nurse practitioner. But when it came to which service really I had the most passion for, it definitely was oncology. Because through all of my rotations, and you would go into, when you did your rotations, right, Miguel, like you go in open mind. Maybe I like cardiology, maybe I like pulmonology, maybe I like OR. But what I found to be the most passionate part of oncology is more of a holistic. So it's a puzzle to me, and I'm always looking at the puzzle, which system I have to fix, and it's multi-systems that we're always attacking. But then there's also the psychosocial aspect of it, as looking at the person as a whole, not just an entire organ that works together at one time. So I find the excitement for me is the gratification of trying to fixing the person to the maximum that they can get at within their journey of their oncology trip that they're on.
Thank you for sharing. Tracy, I'll turn it over to you.
So I'm going to interject a little bit too in becoming an oncology nurse. Being an oncology nurse was important to me because I was a patient first. And so I've sat on both sides of that chair and realized the importance not only of that impact that that patient makes to us, because that's where, for me, the rubber meets the road if you're not doing direct bedside care, talking in the interaction with patients, but realizing on that flip side, that nurse can mean everything to you. It might be something very simple that we do on a routine basis, but it can mean the world to that patient. So I felt like I needed to interject that there. We're going to switch gears just a little bit and I'd like to kind of jump back in and ask, Kathleen, can you take us through what a typical day looks like in your role? What would you typically do?
Well, basically I'm taking care of patients. So basically may start out with a lot of patient education. I go see patients in clinic, in the apheresis clinic or the chemo clinic or over in the hospital. I get my steps in between buildings. So that's a good thing. So how to take care of myself at the same time as working. So we do a lot of education. I mean, patients are at this point, when they're getting the therapy I'm getting, they've been through years and years of therapy. So again, multiple regimens. So again, they kind of know what they know what chemotherapy is, et cetera, but how to tailor the education to them. I'm coordinating and collaborating with the nurses on the floor in the apheresis unit or on the chemo clinic, working with their nurse practitioner and their physician colleagues regarding prescriptions, medication regimens, antiemetic regimens, tumor lysis regimens, et cetera. So kind of doing that kind of education and making sure that happens. I'm coordinating with local hospitals and local community facilities if they need bridging chemotherapies and bridging after they finish a certain part of it and going back. So I'm on the phone a lot. I'm on my cell phone a lot. And just basically triaging calls, problems, et cetera. So I have a little bit of an office job as well as a clinic job. And I run a caseload of patients. So basically navigating, I have so many patients. So the work doesn't leave when I leave the job. It's not like in the, like working in the clinic where you do your 8-hour shift or your 10-hour shift or your 12-hour shift and you sign off and you sign off on to hand off to somebody else and then you're done. The type of job I have stays with me. It's, so I don't have to be on call, there's coverage, et cetera, but I am responsible to make sure to get the patient through the system and to the care that they need.
Very interesting to find out the diversity of that new nurse navigator role. That's such an important role that's kind of taken the forefront in oncology. Thanks for sharing that, Kathleen. So same question to you, Doyle. What would a day-to-day look like for you?
So I do not have patient care currently. I work with an exceptional team, and our charge is to bring together the research community and the inpatient staff to understand the clinical trials, how they work, why it's important that they meet the requirements of those clinical trials. And so on a daily basis, we are answering emails, answering questions from both sides. We're also creating new tools, educational tools for both sides so they can understand each other. And that includes updating our website that we've created, creating any kind of tool or communication that improves not only patient care, but patient safety between the two groups.
Very interesting. Very, very different role than what some people would see on a routine basis. Elizabeth?
So I still work in the inpatient setting. So I am on the floor. We are a joined hematology and stem cell transplant unit. I happen to be our nurse coordinator of the stem cell transplant part as well. So day to day, my main focus is typically patient care, although probably about 50% of my time I spend as charge nurse on our floor as well. So, direct patient care, obviously, and then on the days that I'm in charge, still a lot of direct patient care, but also trying to manage the whirlwind going on around it. And, trying to keep up with staffing and other administrative tasks. It never ends. Being a bedside nurse is very multifaceted. You are housekeeping, you are food service, you are moral support, you are the family member sometimes. So I think you've seen even in your clinical rotations kind of what an inpatient looks like, and it changes constantly, and you get a little bit of everything.
All while wearing roller skates, right?
Absolutely. If only. That would actually make it easier. That would be better.
And Daniel, your day-to-day?
Yeah. I will have to say that I did do inpatient for quite some time, but I'm happy to be I'm on the outpatient clinic end of it. But it's really coordinating of care. It's seeing patients on a daily basis, assessing them, evaluating them, really coordinating with other physicians. Even we do a lot of consulting with community physicians across the country. So it's coordinating care in other facilities. It's actually assessing, definitely like with Doyle, I'm very involved in our research program here also. So it's assessing different adverse events and treatment with patients on research, and really coordinating whether somebody should go on a clinical trial versus on standard of care trial. And really working with the infusion nurses and other inpatient nurses too, because just the way Elizabeth and even with Kathleen, we're moving our patients from outpatient to back to inpatient, whether it's clinical trial versus they need to have inpatient chemotherapy, or moving them into a CAR T cell that's now currently available. It's really a very collaborative experience. Simply, I get what everybody was saying. In the outpatient clinic, is there a clock out time? We all say technically, yes, there is a clock out time, but in reality, due to the cell phone, clock out is 24/7. So I will say, it's a 24/7 job with some downtime between maybe midnight to 3 a.m., but that's okay.
Or if your battery dies on your phone.
Yes, you can only wish.
Yeah, exactly. Oh, I forgot to charge it,
Excuses. Handel, I'll turn it back over to you for the next question.
Thanks, Tracy. Elizabeth, how do you and your colleagues support one another through both the good and difficult times?
A good question, and an important question. Unfortunately, you don't always get to pick your team, but you sure hope for the best. And right now I happen to have a good team. Actually, I feel like I've been fortunate enough to have that all along. So I think we do a good job of recognizing that we work in what can be a stressful environment. And I think you try to take the time to, notice when somebody looks like they're struggling, and we do typically step in. I feel like, especially when I'm in the charge role, I really make a point to walk around and check in with people and say, how are you doing? Can I do something? Can I pass this person's med? Can I hold your phone for 5 minutes so you can, go sit down somewhere? Because obviously in the oncology world, sometimes things don't go well, right? These are very sick patients. And so really stepping in to try to help each other, and then celebrate the good, the victories and, the successes of patients, or, that something funny happened. We have a kind of daily huddle at the beginning of every shift. And part of the huddle is a kudos section. And sometimes it's kudos to you, you survived a horrible 12-hour shift. But other times it's, somebody got engaged, or someone's pregnant, or somebody, got a new job, or, whatever it is. I think sort of just taking that time to celebrate each other and, share a laugh about something that's not work related, making sure that you get a few minutes to sit in the break room and actually talk to your coworkers about something that doesn't involve patient care. I think, we have to support ourselves as much as we support our patients, which is hard sometimes, but you try.
Those are definitely important techniques. Daniel, can you offer some insights into the support systems that you have at Mount Sinai?
So in reference to, I guess, to us as staff or to the patients themselves?
To you as staff and both the patients.
So I want to echo off Elizabeth. I think, there's always mental health support, for staff and for patients themselves. And I think that's also important because, as healthcare providers in whatever role we are still providing some care to all patients and families and to other staff members. Is that, it is very easy to reabsorb other people's issues. And it's something that I think inherently we are as healthcare providers. We're here to make sure that the person in front of us is happy or comforted or supported through their journey. And then we absorb that kind of energy. And I think, having a sounding board, being able just to talk to somebody and say, okay, this is what exactly just happened. I know this is not at you and you may sound angry at that moment and you kind of blast out. But giving that kind of information, saying, I just have to let it off my chest and let it go and not really want a response. Some things can be rhetorical. So we really want to be able to spill it out and move it forward. I personally, I tend to be more like a Patch Adams in the sense that there's always something funny somewhere along the line with a patient or a staff member or something. And I tend to just use humor as kind of my own gesture of life to get through it. But I know other people, their family members do enjoy having that comfort. And this might sound typical, and you probably had to think, just holding somebody's hand. I know we're not supposed to sometimes, but holding somebody's hand, just saying it's okay, or I'm here, or not even saying anything, a quiet, mindful moment, and being present with a patient or your colleague, just being present might help them through whatever they're going through without having to say something to them. And then just getting up and you stepping out of the room allows them to breathe. And I think that's what we don't know how to do. Even though my iWatch tells me to stand up or to breathe, I think we also have to learn how to breathe moving forward.
Wow, those are definitely powerful words. And that's actually a perfect segue into the next question I have for you guys. We all know that the oncology arena can be quite stressful. So how do you deal with these types of stressors? Kathleen, let's start with you.
Well, again, mutual support, whether or not it's a mutual support on the clinic, having a cup of coffee with someone, or happen to go to a bar afterward, work and rehashing it, redoing it, talking to each other, doing whatever. I mean, in COVID times, I was meeting with patients on colleagues on Zoom, because part of the thing is you really couldn't even meet with them anywhere with regard to whatever. You couldn't sit at the same table with them, not necessarily go have a glass of wine with them or go have a cup of coffee with them or something like that. So, I think that mutual support of listening, understanding the situation that they're in, because it's like being in the trenches at days, with regard to the frustration, the anger that things aren't working out for you, and out for not for me, but well, actually it is a little bit about me. If it's not making out for my patient, it's not making out for me. So again, and that frustration of going back, as well as talking it through with someone who knows what that means, because you really sometimes can't keep dumping it on your family. You know what I mean? So, and they don't quite understand it because they're not in the situation you're in, on the unit, in the clinic, whatever. So I think that's really is important, that mutual respect, to be able to listen to someone as well as pay attention to what's going on and say, hey, listen, why don't you give me a call later on tonight? We'll go through this. We don't have time here, and so I think that's really important with regard to how to manage stress and keep it under control, as well as come up with maybe strategies of, okay, this situation didn't work out for me here. How should I have handled it differently? So I've done that a lot, especially as I am more senior. I've hopefully have given some helpful events regarding mentorship of people newer into the nursing profession.
Wow, that's wonderful. Thank you so much. Doyle, do you use any different tactics for stress?
I agree with Kathleen. I think it's very important that we not only assess the patients, but we assess each other as colleagues
That's right.
to see what we're dealing with, and not to be afraid to go up to a colleague and ask, can I help, or take a break and let me take over for you. I think like Daniel said, we take on a lot on ourselves, and we don't have an outlet for it, or we think we're supposed to carry this around. And I try to use the philosophy I give to my patients, which is the 3 Ps, which is stay positive, people, surround yourself with people that support you, and then prayer or spirituality. Those 3 things, I think, will help you make it through the day. The last 2, the people and the prayer, help with the positivity. So it's very important, I think, that we don't dismiss each other as colleagues and our needs, and just focus on the patient, because, even with COVID, it has been a stressful time. And we do tend to, as nurses, tend to carry it all on our shoulders. And if we don't have any place to dump it off, then we burn out, and that's a loss for the nursing profession.
Definitely. I like those 3 Ps. Elizabeth or Daniel, do either of you have any different methods that you guys utilize by any chance?
I like a Zoom-tini.
Hey, it's 5
Nothing
o'clock.
wrong with that.
Yeah, exactly.
I think, yeah, all of those things, everything that's been said, and I like to come home to my family. I think that provides a different outlet. I think you can, take a walk, exercise, meditate, whatever works for you.
Yes.
Yeah.
Trash television, trash TV.
Yeah.
Reality TV, I think, is fantastic to watch, because you could say, oh my God, they're worse than me. So then,
Anything
but I
mindless.
do agree. I think I do. I think we need to deflect sometimes, and we need to, I'm a workaholic, so I use work. It relaxes me to certain degrees, but just hearing trash television, whether it's the housewives of every city in the world, or there's something else going on like Southern Comfort, whatever. But those things, you watch it and you're just like, 90 Days Fiance, you're like, oh my God, can this really be happening? And you're like, okay, so at least they're a little bit more slightly worn out than I am, so I'm okay with that. I was going to say dysfunctional, but I'm not sure if we're allowed to. So, but I think that's how it helps everybody.
I agree. Definitely different ways to deal with stress. So thank you all. Faith, the mic is yours.
Thanks, Handel. You all have shared such amazing insight and just advice into your roles. And for this next question, I'm asking, if I were considering pursuing a career in oncology as a specialty, what would be some words of wisdom that you would give me, or just any nurse looking to begin their journey in oncology? And we'll start with Elizabeth.
I think it doesn't come easily, but learning how to create your personal boundaries is important as an oncology nurse. Of course, we want to connect with everyone, and we want to, feel this thing with everyone, this magical connection. And sometimes that's not the healthiest way to go about it. And so learning your own limits, I think, is really important. And that knowing that, you can give everything you've got to a patient, but you have to save a little for yourself. And you can give everything to your patient, and sometimes they're still not going to do well, and that's not on you. I think those are important things, oncology specific. I think in general, as a new nurse, trying not to get bogged down with so much of the specifics. I was a new grad on an oncology floor, on the floor that I work on now. I think it's overwhelming to walk in and start having all these regimens thrown at you, and there's a lot going on with these patients. I think focus on, this is a human, and I will take care of this human regardless of whatever treatment they are or are not getting, focus on the little things, even if it feels tasky at first. There's a human being. That's the most important thing. The rest of it will eventually come with experience. So just be human first.
Thank you. I'm still learning that from day to day. So I definitely
hard to learn that.
And so Doyle, Kathleen, or Daniel, any other words of wisdom you'd like to add?
I would also say that as a new grad and new going into the oncology field, that oncology is very complicated. So it will take quite a time for you to learn what is associated with oncology. So be patient with yourself. You won't know everything. In fact, I'm sure all of us are still learning as we go along in the oncology field. So be patient with yourself. Find people that you can talk to and answer your questions. And please always ask questions. There is no question that is considered inappropriate or dumb. You can ask it 2 or 3 times, and you will. So don't be afraid to ask questions, and realize that you are a nurse first and an oncology nurse second. So patient care comes first, regardless of what treatment they're on. Just like Elizabeth said, you're a nurse first. And sometimes we get so focused on the oncology part of it that, when something happens to a patient, you run out the door and say, I need a nurse. Well, you are the nurse. Think of that first.
Buck stops with you. No.
Yeah, that's right.
I agree with my colleagues. I think I would say, and coming from a second degree, so there's different challenges. I said, when I went into the field, I think going in a little bit older comes with more life experiences. So things are a little bit more challenging, but it's okay to trip. It's okay to stumble. We're not going to know everything. It's very frustrating, being older and walking in, that you want to make sure that you make the best impression, and you want to make sure that you cross your T's and dot your I's and things like that. But I think it's okay to pause. It's okay to stumble. And, everybody has a phone, so look it up. If you don't know the answer, look it up or ask somebody. And just like Doyle said, ask it multiple times. And it is a fast field. Healthcare alone is growing very quickly on its own. And then in oncology, and pretty much every division of oncology is exploding with new types of therapy. And Doyle does research, right? So we have new clinical trials coming out. Kathleen is in CAR-T, and CAR-T is now, the hot item, right? Everybody wants it. It's the new Gucci of treatment in lymphoma and now in myeloma. So, and again, trying to wrap your head around it. Just when we got understanding stem cell transplant, let's throw another one in there because I had nothing else to do for the day. And it's okay to say, I need to step away for 5 minutes and walk out the door. That's okay to say, I need 5 minutes if you get pressure to step away and then come back to the patient, because it's always going to just keep rolling forward. It's like being in an argument. Sometimes you got to step away from the argument.
And for me, I think the biggest thing as a new grad or a new nurse, et cetera, can do is ask questions. And I know when you're coming on the floor, again, you're going to get different attitudes regarding people who are more open to questions versus some people who may not be quite as open for questions. So find your resources, find the people who you can ask questions from comfortably, not feel whatever, as well as it may not be a nurse. It may be, when I came on as a new grad out of a 4-year BSN program, I had 2 LPNs who worked on the floor with me on nights, and they taught me so much on how to be a nurse at the bedside. I didn't know how to ace wrap a leg. I had no idea what a gastric lavage was when someone was GI bleeding. Oh my God, they taught me so much. They are one of my original mentors. And so basically they were open. They allowed me to ask questions. And I was in charge. And I said, oh, this is kind of odd. And anyway, but part of the thing is, those are the people who and find those people who can really mentor you and find and give you some guidance with regard to whatever question, and just ask the questions. Be confident in yourself to ask the question, because there really is no stupid question. And if someone gives you attitude, ask somebody else, and don't go back to that other person who wasn't as open, because people should be open. We should be able to mentor and support our new grads as they begin their careers.
And ask everybody on the healthcare team. It doesn't matter
right. Exactly
what role, what degree they have. I've learned a lot from every member of the team. I mean, trust me, I never knew how to make a bed till I went to nursing school, and I still don't know how to make a bed. So, and I get thrown out of the room for that. But in understanding that everybody comes with knowledge and experience, and their experience then enhances your knowledge. So it doesn't have to always be a colleague nurse. It could be, your medical assistant that knows. They may not even know how. They probably do wound care better than half of us can. So, because they've seen it for years. So ask everybody on the team what the same question and get the best answer.
And remember that sometimes the most valuable member of that team is the patient themselves. So ask the patient, because they know a lot too. Sometimes, not always, but some of them who've been through a lot of things, they know they can teach you a lot too. So that's a valuable resource too. You don't have to have all the answers. You just have to know where to find them.
Very true. Thank you so much. The value of questions. Noted. Handel, I'll be passing it along to you.
Thank you. I'll be sure to keep these advice in mind when I graduate. So I appreciate it. The next question I have is a very really critical question, and I hope all of you can feel ready to answer this. How can we as nursing students and future nurses become involved to help underrepresented patients and ingrain more trust in these minority populations? The floor is open to anyone.
I'll speak from an inpatient perspective. I think, I work in a fairly urban area, so we see a lot of everything. I think you as an individual have to be open-minded to the diversity around you. I think, again, going back to, we're treating a human, right? So it doesn't matter what they look like or where they came from or whatever, being receptive to them and their needs, which obviously changes. I think Kathleen touched on this a while ago about, these patients come with a wild card deck of psychosocial issues, transportation issues, financial backgrounds, cultural backgrounds. So being receptive yourself, and again, ask questions if you don't understand this person's, motives or, whatever they're trying to get at. Getting to know those patients so that you can develop a trusting relationship with them, I think then makes you viewed as a more valuable resource to them and someone that then they do feel comfortable. And I think, we talk a lot about, there's a lot of talk about health literacy. Health literacy does not necessarily, from what I've seen, that transcends across, you can be Black, you can be white, you can be anything, you can be rich, you can be poor. You still might not know diddly squat about what's going on, especially in an oncology world where things are complex. So, you might be, we've had PhD, professors as our patients who were clearly clueless about what was going on in their oncology journey. So I think recognizing that to some extent, everyone is naive in this oncology world and treating everybody with a sort of level playing field. And then again, developing those relationships so that you can help those people feel comfortable asking you questions and therefore increasing their knowledge. That was a long answer to a short question. Sorry.
No, Elizabeth, I loved it. And I think, I think one of the challenges, and Handel, you brought up a very good point, because, in the current healthcare environment that we live in, whether people are insured, underinsured, or uninsured, and whether, getting more other populations involved is a challenge, and understanding why they may mistrust the healthcare system comes from other cultural experiences that they might have had, heard, or read. Super Google tells a lot of information. And I think Doyle can definitely echo off of this, is that, there's a lot of mistrust in other ethnicities when it comes to clinical trials. So it's really explaining letting them read the information and really asking them, what makes you more hesitant? What do you see here that makes you nervous? Let me give you or help guide you into the next step. And I think that's a greater challenge. But I think across the board, it's from a new grad, and even from in nursing school, I think undergrad, it's getting involved in legislation. It's going to your statesman, going to your congressman, and really saying, how can we as a community broaden the information out there? So we have to take it, not just the healthcare portion of it, it literally has to move into a state or legislative moment. And you guys being the new frontier, right? You are the new engines of healthcare is moving towards in legislation.
Yeah, I agree with Daniel. When it comes to research, I believe there needs to be a greater effort in education for the public concerning clinical trials, as not all clinical trials are for everyone. As we go forward with new therapies and treatments, the clinical trials become more complicated as we learn more about the immune system. So there are certain markers that the clinical trial may focus on that may not include all cultures. But again, as Daniel said, there is a huge distrust of clinical trials when it comes to certain cultures, and that is not their fault, that is our fault for the way we have ran the clinical trials. So there needs to be a greater communication, education, and trust between those that are running clinical trials and those and the public. Until we get that trust back, I think we're still going to have a problem, an issue with getting all cultures involved in clinical trials. So there needs to be a greater effort with that. But I do think that we're making headway. And I agree with Daniel with legislation that you need to be involved as a new grad or undergrad, because you make a difference in healthcare as nurses moving forward. So yeah, I agree with Daniel and Elizabeth.
You're the change agent. And I really don't always like that term, but you are the change agent. You have come in with brand new goggles. You don't have blinders.
And your voice is huge. You have a huge impact.
And you're very social media. Yeah. So you're all there.
And I think one of the other things too is I think we need resources. I think centers that have trials, et cetera, getting them into the communities, et cetera. I think there's another thing with regard to being an oncology nurse and following patients through their trajectory. I mean, you see patients more often. It's not like the emergency room. You're not trying to enroll somebody in something in an emergency room. You're able to develop a rapport with people. So I found in patients of mine who I took care of years ago, who went through a transplant, who then went over and now going to CAR T, with regard to, you have a rapport with people with regard to whatever, and have developed that trust. So it's easier. So, I mean, I think it's tried and true with regard to that, but I think we also need resources for people, again, regarding transportation, et cetera. If they can't get to a research center or get to the clinic and they're required 4 days a week, again, we need to be able to provide that for them if the trial doesn't do that, or a research social worker with regard to that, a research nurse or resource programs, resource specialists regarding transportation, childcare, all that. So, I mean, I think resources too, besides legislation and stuff like that, they need to put resources in to be able to encourage people to be able to say, oh yeah, I'm not really sure about it, but I can't do it because I can't get there. So I can't get there 3 days a week, 3 times a month, you know what I mean? Whatever that is. So I can't participate in this trial that you tell me is really could be beneficial to me. So, I mean, I think other resources also need to kick in too.
I'd like to say one more thing, that a positive that's come out of the COVID-19 is telemedicine, where we can see through Zoom or webinars or things such as that, because one of the difficulties and the stressors that patients and patients' family have is the cost of returning to the institution for follow-up visits, for blood work and things such as that. Now you can do this over the Zoom. You can see your patients, assess them, and they don't have to travel 1,000 miles and pay for a plane ticket or be on the road. We can now assess the patients over a Zoom for follow-ups, and that decreases the stress level and the cost and the amount of resources needed. The days of expecting a patient to come back to the same institution once a month for a follow-up, I think, are over, and rightly so. I think rightly so.
I usually look at the new Zoom, placement as no more snow days for students in primary school. Good points. Definitely, it does narrow the gap with resources that we can use.
Absolutely, and always great to hear such insight from so many different viewpoints, and it all sounds very similar. We all function still the same. All very interesting. What I'd like to do is, as we're starting to close out on our time, I'd like to finish by asking our recent graduate and our upcoming senior student a question. So Faith, as an incoming nurse, what impact do you hope to have as you enter the nursing field?
So I'm really excited to enter the field overall and just experience a ton of growth. As you all emphasize the importance of questions, and even this past semester, like I've definitely learned a lot just by asking questions. Overall, I'm really interested in population health as well as health literacy, which Elizabeth mentioned a little bit earlier. And I'm just looking for ways to incorporate that into my practice, learn more, get involved on the unit, and just honestly be like a sponge and absorb as much information as I can.
Good plan. Good plan. Hundell.
Definitely. I echo what Faith said, but just to add into that, I think something that defines me as a person is I'm a very social being. So a lot of the words that you guys echoed today with, narrowing the health disparities gap, finding ways to, improve access to healthcare for people. I think one of the ways I plan on doing so is by really just getting on a level where I'm able to speak to those people who have access to those, to those resources, whether it be, absorbing those informations on the floor or just participating in more meetings so I can see tangible action items so that we can see, positive results in those sense.
Great words of wisdom to absorb from today. So we've got time for, there was something that was posted in the chat box. And so we've got time for one person to respond to that. We might have time for two, but this is coming from a nursing student. Before nursing school, I've always been passionate to work in the oncology unit. After one of my clinicals where I worked in the unit, I discovered a sad world. At times I would cry just looking at a patient, and for some reason, most of those patients were very nice. So how do we become resilient in such an environment, and how do we fight our emotions?
Don't fight it. Don't fight your emotions ever, first of all. I think the inpatient world is hard because those patients are there because they're sick. An outpatient clinic, people are in and out a lot of times, and that's not a always true statement, but for the most part, people come to the inpatient unit because they're that sick. They need to be there. So yes, it can be a hard world. And I think as a veteran inpatient nurse, we do have to remind ourselves that sometimes we see people and we don't see them again, and that's because they did well. And you have to remember that there are victories. You just don't always see them on the inpatient side because the success is they don't come back. So I think recognizing that, sure, it can be sad, and you can be sad for people. But I think over time, I don't want to say you get hardened, but you do develop a thicker skin, or maybe you don't. And maybe honestly, you realize it's not the place for you, and that's okay too. That's the beauty of nursing, is there is a whole world open to you. You should never be in a job that you don't like for very long if you're a nurse, because there is always somewhere else to be, whether it's day shift or night shift or inpatient or outpatient, research, patient navigation. I mean, there are so many possibilities. And there's nothing wrong with you for thinking that this isn't the right fit for me, that this is too emotional for me for whatever reason, whether it's because it's too personal for you, or maybe it's a bad place to be. Recognizing that and giving yourself the space and credit to determine what is the right fit for you will only benefit you and your patients more in the long run. But don't fight your feelings. They're there for a reason.
Thanks so much for that input, Elizabeth. So I've taken a couple notes, and we're at the point where we're about to sum up. But I took some really interesting notes from the conversations and the questions, and kind of like a take-home list, you would call it: personal boundaries, be patient, ask questions, nurse first, oncology second. I think, Doyle, you said that. That was great wisdom. Okay to stumble, teach, but mentor. Be that mentor. Ask the patient, know your resources, and some of your resources could be the patient. And that we do need more resources always for patients as we develop and move forward. So that's kind of Tracy's take-home list that I jotted down for me to take back with me. I want to thank you all so very much for the wonderful conversations, and for everyone for joining us today. We've truly appreciated your time and the tremendous insights that you've provided by our wonderful panelists, nurses, and of course our nurses to be. We hope that all the attendees today benefited from today's presentation. Want to make sure that you visit our website and follow Karyopharm on social media platforms for more information on upcoming events. And we hope to see you again for one of our upcoming webinars. As May comes to a close, the official Oncology Nursing Month, not that we have 1 month, but the official Oncology Nursing Month, we celebrate the many facets and faces of oncology nursing, as stated so eloquently by the ONS. An oncology nurse is there to explain the diagnosis, guide patients through treatment, celebrate victories, and comfort them through the unimaginable. Even faced with the unimaginable, provide fearless commitment and endless compassion to your patients every day. Just want to say thank you so much to the outstanding oncology nurses and on our panel. So Daniel, Elizabeth, Kathleen, Joyle, and a big thank you to Faith and Hundel, who also assisted in moderating this discussion today. I want to thank you again and enjoy the rest of your day.
Thank you.
Bye.
Good luck, guys.
Yeah, really. It's fun. It's a great discussion.
Thank you.